Hello, Dr. Darty here with one of my favorite topics, special senses, the eye and the ear. Before we start, let's have a little trivia. What do you think is the furthest object, most distant object that can be seen with the naked human eye? I used to ask this as a bell ringer in my A&P classes, and people would say, well, I think I can see a mile. Or then I'd point out to them that, can you see the sun? The sun is 93 million miles away, give or take, and that would give people a hint. Actually, there's some dispute about this, but apparently on a clear night, if you have good vision and you're in an area free of light pollution, you can see the constellation Andromeda, the Andromeda Galaxy rather, which is 2.5 million light years away. Other sources say Cassiopeia, but let's go with the Andromeda for right now, the Andromeda Galaxy. Think about what that means. Light left some stars so far away that it took 2.5 million years for the light to leave that galaxy and reach the place where you are standing on that clear night. And you have on the backs of your eyes, the back surface of your eyes, a whisper thin layer of cells that are so sensitive to that light radiation that they can detect it. Now that is amazing. If that's not doesn't leave you with a sense of awe and wonder, then there's no help for you or me. But the other amazing thing is that these wonderful instruments are typically dealt out to a customer. So eyes are pretty wonderful. True confession, if I had more dexterous hands and more nerve, I would have liked to have been a pediatric ophthalmologist. Which brings up what the specialties that deal with eyes and ears are called. We're going to do eyes first. An ophthalmologist. Notice that the PH is pronounced like the letter F. It's not ophthalmology, it's ophthalmology, hard to spell. And the medical doctor who has specialized in that is an ophthalmologist. Now, another eye healthcare professional that you're probably familiar with is an optometrist. They don't have a medical degree. They are doctors of optometry. They have a special separate school that they go to. And over the years, they have actually assumed many of the non-surgical abilities that previously were restricted to ophthalmology. So optometrists now often prescribe medications. They do a lot. They don't typically perform much in the way, anyway, of surgery on the eyes. Then we have opticians. Opticians are specialists in making and fitting eyeglasses, but that now also can include contact lenses. So opticians are specialists in correcting vision, if you will. Now, for ears, most of the medical part of dealing with an ear is by what we frequently refer to as an ENT for ears, nose, and throat, and that is technically an otolaryngologist. So an ENT or otolaryngologist is a specialist, typically a surgical specialist. So like if your child needs, quote, ear tubes, polyethylene tympanostomy tubes, then that would be the specialist who inserted those. But there's a lot of overlap because neurosurgeons, now that we have cochlear implants, they get in on the action too sometimes. And of course, we have audiologists who are specialists in hearing and fitting assistive hearing devices. So there's a lot of interaction between these different health professionals, and probably more that I've neglected to mention. Okay, so let's talk first about eyes. There should be, yes, there's a nice couple of drawings on page 282 in your text, and these have to do with what we call the accessory structures of the eyes. There are a lot more than are mentioned in your text, but there are several good ones there. They mention the apparatus called the lacrimal apparatus. Lacrima is Latin for tear. So the lacrimal apparatus makes tears, and you make tears obviously not only when you're crying, that's when you make more tears, but your lacrimal apparatus is situated, as the drawing points out, in the upper outer corner of each eye, and it continually produces tears that wash across the eyeball and leave your eye, under normal circumstances you're not even aware, by a tiny little opening at the inner corner, or canthus. Canthus is the word for the corners of your eyes. You have a medial canthus and a lateral canthus on each eye, plural canthi. So leaves through the medial canthus, a little hole there, travels down the nasolacrimal duct, which runs through your nasal bone, and then the moisture typically just becomes part of the moisture in your nose that's used to humidify air as you breathe in. But if because of allergies or a really sad movie or story, you begin making an unusual amount of tears, those tears will overwhelm the ability of your nose to use them for just humidifying, and you will start sniffling or need a hanky to blow your nose. So that's the nasolacrimal apparatus. Because your eyes are so special and so precious, about 70% of what you sense in the world is the estimate comes in through your eyes. We have some other structures. We have eyebrows. Currently, they are very fashionable. If you watch the newscasters on TV, you know eyebrows are a big thing, that are designed to help to keep sweat from dripping into your eyes. We have eyelashes, little hairs. Those are often augmented as well if you watch TV, that help to flick away dirt or insects or stuff that you don't want in your eye. Let's see, what else? Well, that's most of the external protective structures. We also have 6 different muscles that move each eyeball. Very interesting to learn about in anatomy and physiology. We won't go into that here. Those are operated by some of those 12 cranial nerves that we discussed back in the nervous system chapter. If you hear a corgi barking in the background, I'm sorry. She's not really interested in this. All right, so some of the words that we notice in the first table we've already gone over. We didn't mention conjunctiva. The lining of your eyelid, upper and lower, reflects back on itself, and this transparent lining also goes across the front of your eye, and that's called the conjunctiva. And if you get pink eye where it's inflamed, that's conjunctivitis. So the conjunctiva is also part of the protection for your eye. The bony protection of your eye socket, if you will, is called the orbit, and several of the craniofacial bones make that up. Again, if you take A&P, they'll have you learn that, but you don't have to learn it for me. The area around your eye socket is called the periorbital area. Children sometimes develop periorbital cellulitis, an infection that can be quite serious in the tissue, soft tissue around the eye. Photophobia is mentioned. That's when light hurts your eyes. People who have a corneal abrasion, where they get a scratch on their eye, we'll talk about the cornea in a minute, it's very sensitive. They often can't stand to have bright light, and that's called photophobia. Some diseases and nervous system conditions can also result in photophobia. It means you don't like light. All right, moving on. On your next big table, on page 285, another word that they mention is blepharitis. The word for your eyelids, they're technically called palpebrae, and the little slit between your upper and lower eyelid that you can open wide is your palpebral fissure. But if the lining of the eyelid becomes inflamed, that's called blepharitis. And if you have cosmetic surgery to lift your eyelids, I haven't gone for that yet, but any day now, or to take the bags out from under your eyes, that's called a blepharoplasty. So when you hear blepharo, that's referring to your eyelids. Ptosis, an important word. I'm glad I saw that there. Notice it has a P in the front. It's not ptosis, it's just ptosis. A ptosis is a droopy eyelid. I'm not very good at it. Like one eyelid would be ptosis. Like if someone has some central nervous system impairment that causes them to have trouble keeping their eye open, they might have a ptosis of one eye. Or people with muscular diseases like myasthenia gravis may have bilateral ptosis like that. If you saw most of my photographs, you'd think I have ptosis. I'm a blinker. Moving on in page 287, a lot more new words. When the eye muscles are not properly balanced, That gives rise to a condition where the eyes don't focus in the same direction, and that's called strabismus. Or in the old days, they called it squint. We don't mean that usually with squint, but you still see that sometimes used. The most common strabismus is an eye turning inward, deviating inward inappropriately, and that's called esotropia. Less common, an eye might deviate outward, and that's called exotropia. If one eye deviates slightly, typically, and your brain, as it develops in young children, has to decide which eye gives me the better image, or maybe one eye just doesn't see as well, it's markedly nearsighted. We'll get to that in a minute. Not as good. The vision's not as good. As your visual cortex back there in your occipital lobe develops, it's getting mixed information. It's getting a sharp image from one eye and a blurry or inconsistent image from the other eye. So what a developing child's brain decides is, I'm just going to go with the good image. And it stops developing the visual cortex from the bad eye. And really, the bad eye sort of just decides what's the point, if you will. Of course, it doesn't decide that. But what happens is that eye becomes not focused as well. And we call that lazy eye or amblyopia. You may have seen little children patching an eye, and you might be surprised to learn that the eye that's patched is the good eye. We want to make the weaker eye take some more responsibility. Do you hear that, you group members? So we try to get the weaker eye, we force it to strengthen itself because we take the good eye offline for a bit. So when you see children with a patch on their eye, a common reason for that is they're being treated for amblyopia. What else here? We got all those. Accommodate. We say someone who's accommodating is, easy to get along with, very helpful. But accommodation in the eye means something different. When we need to see something up close, like a book, two things happen. One is our lens changes, and we'll get to that in just a minute. But the other thing is eyes normally deviate inward. Now, you can do this yourself. I'm not going to do it for you right now. But if you take a pen or a pencil and you bring it close to your eye, don't jab yourself, then you will notice that your eyes begin to deviate inward. And that's part of accommodation. The other part, which involves the lens, we'll get to in just a moment. Let's do the layers of the eyeball. The eyeball's so great, and it's very manageable to learn the basics. The outermost layer of the eyeball, called the fibrous layer, has two components. The white of your eye, which is called the sclera. It's got some fairly durable connective tissue in there, and normally it's white. We know that in jaundice, you can develop what we call scleral icterus. You remember icterus is yellow coloring with jaundice. So one of the first places someone who has liver disease demonstrates that is the whites of their eyes become yellowish. That's called scleral icterus. You may have also awakened one day and you've got a little broken blood vessel in your eye. It can look pretty dramatic, but usually doesn't mean anything. So you can have a little scleral hemorrhage, or if you got poked in the eye, you may have a traumatic scleral hemorrhage, and that's like a broken blood vessel in the white of your eye. As the sclera reaches the front of the eye, it becomes clear because light has to get into your eye, and that's what is the cornea. It kind of bulges out like a bay window. Lay people often have the misunderstanding that the lens does most of the focusing of your light on your retina, but really most of the focusing is done by the cornea. The lens is just a fine tuner. Now when we talk about focusing, you've played with a prism before, a magnifying glass. You know that as light goes through a curved surface, it is bent, and we call that refraction. So because the cornea is curved outward like a bay window, as light goes through, it is bent or refracted. Now, let's see. The next layer in is called the vascular layer. You don't have to know that. But the choroid, which is the blood vessels that nourish all the layers of the eye, is there. But as that layer approaches the front of the eye, several interesting things happen. One is that that layer also includes the iris, the colored part of the eye, named for the goddess of the rainbow. And as you know, the iris comes in all different colors. People who have hardly any pigment in their retina have icy blue eyes, and people who have a whole lot can have very dark, almost black eyes. The only pigment in all colors of eyes is brown. It just depends on how much you have. So I don't have icy blue eyes, but my eyes are on the blue-gray side. So I have less brown pigment than maybe some of you who have brown eyes, green and hazel eyes, somewhere in between. So the iris focuses like a shutter to determine how much light comes in through the hole in the iris, which is your pupil. In bright light, and you see I have this room very brightly lit, so my pupils are fairly small, but if I were in a darker room, my pupils would get larger. So that's what the iris does. It controls the amount of light. There's also a structure there that you can't see because it's behind the iris called the ciliary body. And it makes a clear, thin liquid that lubricates the front of the eye and supports the lens within the eye, but right behind the iris there. So let's talk just a bit about the lens. It is controlled by some muscles, tiny little muscles, and they are connected by tiny, tiny little strings or ropes. And when a lens thickens, that allows the light to be bent and focused in a tighter area on the retina. So when I read, then my lens would get thicker. You can't see that happening, but that's what happens. If I wanted to look out across the street to see what my neighbors are up to get far vision, my lens would actually relax and flatten out. Now your lens is a bit like an onion. Before you're born, it's just a little waxy layer, but as your lens develops, it starts developing layers of this crystalline protein, almost like layers of an onion, and it continues throughout life. So by the time you get to be my age, it hasn't happened yet, you've built up enough layers that parts of the lens may become opaque or solid, and that's what a cataract is. Some of you may know folks who've had cataract surgery. It can happen at any time in life, especially after an injury to the eye. Certain prenatal infections can cause children even to be born with cataracts. It's not common. But my ophthalmologist has told me that if you live long enough, you're going to get cataracts, but I'm not there yet. What has happened, and it happens to most people in their late 40s or in their 50s, is they start noticing that print seems smaller and you want to hold the book out further and further. You may hear people joke that my arms have gotten too short. That's because the lens has become stiffer and can't thicken up to discriminate fine things like print, and that's when you need cheaters or reading glasses. So that's what's going on with the lens. Now, the innermost layer of the eye, the most fascinating part, is the part that has the retina. The retina is held in place by this thick, crystal clear jelly called vitreous, meaning like glass, the vitreous humor. We don't mean humor like ha-ha, we mean humor like a liquid or a fluid. So the vitreous humor fills a jelly-like, perfectly clear substance, fills your eyeball, and keeps your retina, that very thin layer of photoreceptors, light sensors, stuck to the back of your eye. If you lose the vitreous because you got a cut on your eye, the eyeball collapses and the retina detaches. And a retinal detachment, you may know, is very serious, very sight-threatening. All right, so we've got vitreous inside the eyeball, contributing to its pressure. And we have the retina across the back of the eyeball. A lot of the retina has photoreceptors called rods. Rods are good at dim vision. So if you get up at night and the lights in your house have been off for a bit, you may be able to see quite a bit. But if you turned on a bright light and then turned it off, in a few minutes, you would have lost that ability because the pigment that allows the rods to work is bleached out by light. That's why if you want to look at stars, it's better to be out in an area where there isn't any light pollution. So for dim vision, that's rods. They don't sense color, and that's why if you look through a dimly lit room, you can't tell what color your couch pillows are or whatever, whatever's in the room. If I came into this room, I couldn't tell what color the books on the shelf are. There's an old saying that all cats are gray in the dark, and that's probably where that came from. Okay, so the most magical sensitive cells are the cones. the cones, and you may have a drawing in your book. Do they have a drawing? They do. On page 290, they show you that the cones actually look like cones. They are sensitive to bright light, and they can distinguish color. So cones are really pretty spectacular. There are more cones in the macula of your eyeball, in your retina, than there are anywhere else. And the most of them are found right in the center of the macula in a place called the fovea centralis. So that's the only spot on your retina that allows you to see clearly enough to be able to distinguish the print in your book. You may have heard of a problem that strikes fear in the heart of people your instructor's age called macular degeneration. It's an eye disease that is manageable but probably not totally reversible, where the macula, the area of sharpest vision, begins to disintegrate. It's damaged so that people only have peripheral vision. And I may post something if I can find it to show you exactly what that would look like. So that's a serious problem. Another problem besides cataracts and macular degeneration that's associated with aging is glaucoma. Glaucoma is an abnormal buildup of pressure in the eye. Now, we said that most of your eyeball is full of vitreous humor that keeps your retina attached in the back, the jelly-like stuff. But toward the front of your eye, the liquid produced there is called aqueous. Some people say aqueous. I learned aqueous because it means watery. Watery humor, aqueous humor, that helps to hold the lens in position. It is recirculated all the time. We won't get into the structures and the specifics, but you make it and your body needs to reabsorb it through some special capillaries. So when anything gets blocked in that system, much like we talked about hydrocephalus from the ventricular system in the brain, the fluid builds up and it builds up pressure, and that's called glaucoma. If enough pressure builds up, it can actually transmit it all the way to the back of the eye where it starts damaging the retina. So in some parts of the world where healthcare is not as readily available, glaucoma is the leading cause of blindness. In this country, when you go to the eye doctor, either the optometrist or the ophthalmologist, you get either a tonometer put on your eye after numbing an instrument, or more likely you get a little puff of air in your eye. You try not to flinch, but you always do. That's to measure the intraocular pressure, the pressure inside your eye, to make sure you don't have glaucoma. All right, and it's very treatable if it's discovered early before it does any real damage. All right, there's some interesting pictures on 292, and they show you what can go amiss with this great little camera system we have in our eyes. An eye that has normal vision is shown for you at the top of page 292. But a lot of us don't have normal vision. We may be nearsighted, that's the most common, and that's called myopia. The adjective is myopic. So as you can see, the middle picture, the eyeball is foreshortened. It's sort of squished in the anterior-posterior direction, causing the light, when it's focused through the cornea and the lens, not to be focused sharply on the retina. Fixed with either contact lenses or eyeglasses, or now it can be corrected surgically. If you look at the, they show you what it looks like when it's corrected in the bottom picture. Farsightedness is the opposite. The eyeball is, I just did this completely backwards. I'm so sorry. In myopia, the eyeball is too long. In farsightedness or hyperopia, it's too short. I'm not going to redo this whole thing. Just let's go back and go over it one more time. In myopia, the eyeball is shaped like an olive. It's too long. In hyperopia or farsightedness, it's too short. Presbyopia is a completely different thing. That's what I mentioned to you before. When your lens gets stiff and can't focus light properly, it literally means old eyes. So presbyopia is what people my age have reading glasses for. I apologize for having misspoken there. Then in page 295, they move on to disorders of the eye, and many of those I've already talked about with you, so we won't go over more of that. The instrument that we use to look in your eye is called an ophthalmoscope. Pictures of the retina there on page 296. Very nice. Then we have on page 299 some ways of assessing vision. There's the Snellen eye chart, letters for literate adults, pictures for children. And they also mentioned, which is fun to play with, the Ishihara color system. And they have a few of the plates there for you on 298. I've put a link in your content area if you want to know more about that. It turns out a lot more people have a little bit of color blindness than they're aware of. Might explain why your beloved can't quite get his or her clothes matched up just right. Then, moving on page 301, there are several more words, most of them not as commonly used as the ones we've talked about. Same on 303. We got to give a little time to the ear here because ears are pretty terrific too. So on page 306, there's a great picture of the ear. The ear has three basic components: the external ear, the middle ear, and the inner ear. Your external ear is everything from the outside down to the eardrum. Your middle ear is from the eardrum through the little bones or ossicles in your ear over to the oval window. Students used to ask me, is your tympanic membrane or eardrum considered part of your external ear or your middle ear? And that's sort of like saying, is the front door of your house on the inside or the outside? The outside layer of the eardrum is part of the external ear, and the inner surface is part of the middle ear. So, as we said, the specialists who deal with hearing include an otologist, but typically that's folded into the ear, nose, and throat specialty, the otolaryngologist, and the audiologist. So the external ear, we could talk all day about how it's shaped so that it sort of acts like a satellite dish to bring sound down through your ear canal. Most of the time, there are only a couple of problems that present with the external ear. One is swimmer's ear, and that's called otitis, meaning inflamed ear externa. So the ear canal becomes inflamed, typically with some bacteria that like water, like Pseudomonas, and some fungus. There's several different treatments for that, quite effective. Then the middle ear, which is where pediatricians spend their day all too often, is where when you say my child has an ear infection, it's their middle ear typically that's infected, and that's otitis media, meaning the middle ear. The middle ear takes the sound waves that cause the eardrum to vibrate and transmits that sound across a chain of three little bones that you may have learned earlier in school by their common names. There's the hammer, the anvil, and the stirrup, because that's what they look like. But in med speak, those are called the malleus, the incus, and the stapes. The stapes or stirrup is the smallest bone in your body. More for your trivia nights. All right, let's go on a little bit. Effusion is a collection of fluid. When we have otitis media, there's usually a layer of thick fluid or pus in the middle ear that you can see with your otoscope. External ear. Your eustachian tube is a tube that runs from your middle ear to your throat. It helps to keep pressure equalized in that middle ear cavity. So if you've been on an airplane, you say, oh, I need to pop my ears. You might chew gum or yawn. Little children have eustachian tubes that don't always work very well. They're short, they're floppy, they're more horizontal. So young children are more prone to that getting plugged off. And then the germs have a little house party up in the middle ear and you end up at the doctor's office. Let's see. Disorders of the middle ear. Perforated eardrum is when you get enough pressure that it actually bursts. We see that sometimes, and then there's yucky drainage from the ear. You can also get a perforated eardrum by not following the advice on the package and sticking a Q-tip into your ear. Little kids are frequent offenders on sticking things into their ears. Let's see what else we want to talk about here. So where does the hearing actually take place? The sense of hearing takes place in the spiral organ of Corti, which resides in a bony chamber that looks like a snail inside the bones of your skull, and that's called the cochlea. So the cochlea is the structure that houses your organ of hearing, which is actually called the spiral organ of Corti. You don't need to know that. The other thing, that action that happens in your inner ear, is it contains your sense of balance, called your vestibular sense. It's like a gyroscope. So if you close your eyes and tilt your head, you should be able to tell, even without looking, that your head is tilted. And that's because you have a very fancy system of fluid and tiny little rocks called otoliths inside that fluid that tickle nerves when your head is twisted from side to side. Tinnitus or tinnitus, I hear them saying tinnitus on commercials now, but I learned tinnitus, as your book says, is ringing in your ear. It can be caused by nerve damage. It's not always ringing. It can be a clicking sound or a scraping sound, an abnormal sound that isn't there. Looking on. The test we do to determine how well you're hearing is called audiometry. The instrument is called an audiometer. And again, that test is usually performed by an audiologist. Another big word that is seen on page 319 is tympanocentesis. That's where there's a perforation, deliberate perforation of the eardrum to drain off fluid. Most often, that is accompanied by the insertion of a tube, a PE or polyethylene tube, to allow the ventilation of the middle ear, since your eustachian tube isn't doing its job very well. Oh, is there more? Is there more? I think we're about there. Oh, the other thing that can happen, I bet you knew this already, is wax can build up. The medical name for wax is cerumen in the external ear, and there's a lot of different ways to remove that. Your book mentions curette, and the procedure is called a curettage. That's mentioned at the top of 323. I think that's enough words about the eye and the ear for today. Again, your book has a very nice chapter, does a good job with this chapter, and has several good tables with good pronunciation guides. But if you have any questions, let me know and I'll try to answer them. Thanks for watching.